Without further ado, let me begin. Let's face, to start off with, some of the figurative elephants in the policy room. And by elephants, obviously not talking about literal elephants. I'm not even talking about Republican elephants, although party politics will be coming into play, as you will see. So I want to get started by talking a bit about some of the basic, again, policy building blocks when it comes to coverage for America's seniors and those entering the final stages of life. Some of this will be a review, most likely for many of you, but hopefully I can add a twist here or there that will enhance it a tad. So to start off with, I think we're all familiar with Medicare and Medicaid writ large. But when we talk about both these programs, it's vitally important to really break them down into their constituent parts and to get a sense of really what's inside, what those moving parts look like. That's particularly the case when it comes to Medicare. Of course, Medicare is comprised of several different parts, as they are known. We are now up to 4 parts, to be exact. We may add more in future, but that's what we're currently up to. So Part A is the part of Medicare that perhaps the greatest number of people are familiar with, and that is the original core of Medicare. Part A is a compulsory contributory program that largely covers hospital and largely covers acute care. And as you know, is implied by the term compulsory, everyone is pretty much automatically made a member of Medicare. You start paying into it, obviously quite early in life. We all can see out of our paycheck where Medicare payments are taken out. This is where they are going. Largely to this Part A program. And again, most everyone contributes to Medicare, Part A particularly. Now, Part A was constructed in this way very deliberately. There's a reason it looks this way. And that is because when it was being designed in the middle part of the 20th century, health reformers were very concerned that they shake off the suspicions that surrounded anything that had even a vague whiff of socialized medicine. And the way to do that, the way best to do that really, was to model Medicare, this new Medicare program, off of what was at that time becoming a very popular program, and that is Social Security. So Social Security had been around by the late 1950s and the 1960s for about 30 years, had quickly gained in popularity, that public pension for retirees, paid for out of a trust fund that everyone contributes to. And so this was an incredibly popular program. And so the best way to get Medicare passed was effectively to make it in the image of Social Security. And to pass it that way. So it is perfectly modeled after Social Security that had come 3 decades before, and again, quite deliberately. But that's not all there is when it comes to Medicare. Of course, we have our 3 other parts. Part B generally covers doctor's visits and much in the way of preventive care. So care provided generally outside of the venue of hospitals. And it is a voluntary program. You may in fact opt out, though relatively few people do. So it is not compulsory. So Part B looks different already right off the bat. Not only does it cover different things, but it's also different in terms of its basic program design. It is not compulsory. Medicare Part C and D came quite a bit later compared to these 2 original parts. Okay, so Part A and B came around in 1965. They were signed. We're going to see a picture actually of the signing ceremony in a moment. and I'll let you in on some of the history that was involved there. But Part C didn't really come around, wasn't firmed up until the mid 1990s or thereabouts. So it's now been with us, 20, 25 years. And Medicare Part D is even newer. It did not come around until 2003 under what was known as the Medicare Modernization Act. So what is Part C? Part C, you may not know it as Part C. You may in fact know it as Medicare Advantage. So Medicare Advantage is the part of the Medicare program that is still financed through federal funding. So the federal government is still financing medical bills, but they are effectively being channeled through private insurers. So that is Medicare Advantage. And you may wonder, well, what is the advantage in this case? Well, Medicare Advantage plans tend to cover more than so-called traditional Medicare does. So it has extras added in. Those extras could include vision coverage, dental coverage, for instance, other areas that are in fact gaps within the original Medicare program. Now, this does come with premiums that you pay in. And in fact, the federal government pays Medicare Advantage plans even today at slightly higher rates than they do the same group of people within traditional Medicare. So again, this has been around since about the mid 1990s. It was an attempt really to bring the private market into Medicare. And it's actually been somewhat successful in that regard, because at latest count, a bit over a third of Medicare beneficiaries receive their coverage through a Medicare Advantage plan. And that number seems to be steadily rising. So it has gained in popularity. And what's fascinating from kind of a political standpoint, as opposed to a policy standpoint, but a political standpoint, is that Medicare Advantage began as very much a Republican, solidly Republican proposal, with quite a bit of skepticism on the part of many Democrats, as you might imagine. But over the years, over the last 20 some years, it has gained in popularity so much that Democrats now find it difficult to avoid it. And they have perhaps reluctantly come to support the program as well. So it now attracts bipartisan support. That was not the case when it first came online in the mid 1990s. So finally, we come to Medicare Part D. There's a nice little mnemonic, I like to think, that comes with Part D. The Part D stands for drugs, prescription drugs in this case. So Medicare Part D came along, as I said, in 2003 as a result of the Medicare Modernization Act. It was, at the time, the first significant expansion in Medicare since the program was passed back in the mid 1960s. So we went nearly 40 years before Medicare was significantly expanded. Now, that's not to say that there weren't smaller expansions in previous years. So one of the most significant of those was perhaps the expansion to those with end-stage renal disease that occurred in the early 1970s. But even that, again, only occurred about 6 years after the establishment of Medicare. We went over 30 years in which there really wasn't any significant expansion of Medicare, despite the goals and what was envisioned by the program's original framers. Finally, our final policy building block here when it comes to care for seniors is, of course, Medicaid. Medicaid is a major player, sometimes overlooked, in terms of the huge policy footprint it has when it comes to senior care. And the reason it plays such a vital role is that, again, there are significant gaps in the original Medicare program. Perhaps the most significant of those gaps is long-term nursing care. Medicare, for the most part, and there are some exceptions, but for the most part, was not designed to cover long-term nursing care. So in fact, many people have to look to Medicaid in order to finance long-term nursing care. And as many of you are probably familiar with, this often entails a significant drawdown in funds, in earnings, in order to become eligible for the program over time. And we'll talk a little bit more about that in a bit. So I promised that I would have a picture from the signing ceremony of Medicare. This is it. Does anyone know, I'm going to ask for a little audience participation here. Does anyone know who the gentleman on the right holding all those pens happens to be? Any guesses?
Truman.
That's right. Exactly right. Very good. I knew you'd get it. Very good. So there's a reason that Harry S. Truman is present, the guest of President Johnson, shown at the left here. Again, this is the occasion of the signing of Medicare and Medicaid, signed as amendments to the Social Security Act in 1965. And the reason that Harry S. Truman is present is that Truman had been part of the ongoing political battle for universal health insurance, actually going back to his time in the White House at the tail end of the 1940s. He was the first president to champion in any significant way universal health coverage. And the plan he had in mind actually mirrored that of Germany, in that you would have very heavily regulated, largely private insurance companies, with the federal government covering portions of the population that were not covered by private insurers. So it was not socialized medicine by any stretch of the imagination, but that boogeyman, if you will, very much appeared in the debate over his national health insurance plan during the 1940s. It got bound up in Cold War politics. So opponents claimed that it was a Soviet plot. And it also got bound up when it came to race politics as well. Because one of the greatest fears of particularly Southern Democrats at this time, from the 1940s through the 1960s, was that any national health insurance, any national program like this would come with a directive that would lead to the desegregation of Southern hospital facilities. And in fact, under Medicare, that is exactly what happened. There's a brand new, fairly new now, book out on that topic about how the signing of Medicare became a vehicle effectively for the widespread desegregation of hospitals in the South. So this debate over national health insurance got bound up in Cold War politics and race politics. And both those major conflicts, those defining conflicts, are one of the reasons why, arguably, we have never gotten to universal coverage. It's been a much narrower journey, as we'll see. So Harry S. Truman, the first president to champion universal coverage. And when President Johnson signed Medicare and Medicaid into law in 1965, he invited the Trumans to the ceremony. And President Truman was made Medicare beneficiary number 1. His wife was Medicare beneficiary number 2. So that is the signing of Medicare. What's important to note about this, though, this period as well, is that originally Medicare Part A, Medicare Part B, and Medicaid were 3 different pieces of legislation that were championed by different constituencies. So Medicare Part A was the original progressive program designed to cover mainly seniors. Part B originally was it's a voluntary program. And it was one of the somewhat more conservative alternatives that was presented, largely by Republicans and conservative Democrats. And finally, Medicaid was a third alternative. And it drew on a previous program that had actually already been in place. And that was a program that basically directed grants to states in order to ensure that those who were poorer within those states could receive coverage. And so these are three different programs. Medicare Part A is the original Progressive Core program. Medicare Part B and Medicaid were more conservative alternatives that President Johnson tacked together, added them all together to get them passed as a single package in 1965. It was actually an act of what I consider to be political genius, in that it allowed Johnson to share credit with those who would have otherwise opposed him. So again, as I've said, Medicare was a part of what appeared to be a path to more universal coverage. This had been a battle that had been waged all the way from the 1910s through the 40s and indeed beyond. Initially, the drive was for universal coverage nationally. That would be at least partially financed through the federal government. However, time and time again, due to opposition from various quarters, including, again, as I mentioned, Southern Democrats, for reasons of race politics, but also organized medicine. So the AMA, one of the stoutest opponents of universal coverage. So elements of organized medicine as well, small business groups, and indeed large business groups, the Chamber of Commerce, groups like that, also opposed. So on repeated occasions, the apparent drive toward universal coverage was turned back. And as a result, these reformers who had been battle tested again and again finally decided to, rather than try to cover everyone, narrow the scope of their drive for coverage to those that most people could view as being broadly deserving. And that at the time was seniors for the most part, who were left outside of the private employer-based system for the most part. Now, early framers, early Medicare boosters, as I say on this slide, made it pretty plain that, yes, they were starting narrow, they narrowed their scope, but they were looking to expand it. So they, over time, envisioned simply lowering the eligibility age over periods of time and getting to universal coverage that way. They were quite candid about it. However, for a variety of reasons, including a souring economic climate and a more conservative political era starting in the early 1970s, that did not come to pass. And so instead, as I've said, we had a situation where the Medicare program and to a large extent Medicaid sort of became frozen in time. You don't see significant expansions really of either program for the most part until, again, you look toward the 1990s, beginning with the Children's Health Insurance Program, and especially with the Medicare drug benefit in 2003. But again, you go a whole 30, 40 years in which there are not significant expansions that are passed, despite, again, the aim of those who were supporting the program at the start. So I mentioned that long-term nursing care does not, for the most part, fall under Medicare. I'm sorry, you'll see me glancing out the window to make sure I don't see the school bus coming. Again, not covered under Medicare. However, there are some that could consider to be exceptions. So there is coverage under Medicare for some long-term care that can be seen to be going toward the decline, arresting the decline, of a terminal condition. And Medicare does cover much in the way of hospice care. But outside of those specific examples, for the most part, Medicare was not designed to cover long-term nursing care. And this is something that, for those outside of medicine, for those outside of health policy, this is something that catches many people by surprise. And that I think it is incumbent upon us to make sure that as much as we can, we get the information out there when it comes to, what Medicare does not cover and what Medicaid does cover. So outside of long-term nursing, even Medicare still doesn't cover everything or nearly everything. There are huge gaps. There is a reason that there is an entire class it's huge be covered under Medicare Advantage, for instance, but traditional Medicare, right? Dental care, eye exams, plastic surgery, and again, that biggie there, long-term nursing care, not covered under Medicare. So that means that many seniors must fall back on Medicaid, and many, in fact, do. And it's fascinating to me, therefore, this headline statistic here, that if we take them together, seniors and people with disabilities account for only 24% of overall Medicaid enrollment, but a full 63% of the spending. And if we just take seniors into this equation, you can see it's 9% of enrollees, overall enrollees. So a rather fairly small proportion, but that adds up to those 9% translate to 21% of the overall expenditures. And again, the overall expenditures for the program around 400 billion, at least as of 2011. It's probably significantly higher now. I should probably update that slide, in fact. So this creates, of course, a very difficult situation for many individuals and many families, a situation that requires a significant amount of coordination and coordinated action at times, long before one approaches a point where one needs long-term nursing care or assisted care. So, some, of course, are going to be eligible for Medicaid immediately on the basis of lower income, retirees particularly. However, others must spend down assets to become eligible once nursing care is required. And there are maximums to the amount that can be held in order to remain eligible, either as a single individual or a married part of a married couple. And if, again, you try this to spend down or to transfer assets within 5 years of reaching that point, there's a look back period. That means that people can incur penalties, as many of you are probably aware. And so, again, it creates a very perverse sort of policy environment. And a very difficult situation that requires quite a bit of planning for many individuals and families when we're talking about ensuring eligibility for Medicaid. And for many, again, we're talking about that because many people find it exceedingly difficult, of course, to finance long-term care, particularly out of pocket. This is something that is out of the capability of most. That remains the case. However, this also means, that there are significant gaps when it comes to, the caregivers that may be available. Many people must turn to family members, and this cost is not effectively taken into account when we think about our overall economy. And, as part of the COVID-19 pandemic, many of us are becoming quite aware of the cost of care that is provided by family members and largely uncompensated, again, particularly when it comes to women, of course. So if we look at the economic impact of caregiving, it is thought that these free services, which of course are not free at all, come to around $306 billion, a very large figure. Of course, I said, women are disproportionately affected. Women average 11.5 years out of the paid labor force because of caregiving responsibilities. And American businesses lose between 11 and $29 billion due to the need to care for loved ones. And now, obviously, for 50, and these are for loved ones 50 years and older alone. So we're not simply talking about parents, those caring for children, but we are, in fact, in many cases, talking about those who are caring for older family members. And again, the fact that it falls onto families is partly a result of the insufficient policy infrastructure that we have in place to ensure quality care for older Americans. Fortunately, outside of the rather sparse federal arrangements that are in place, there are some stopgaps that are in place at the state level here in New York State. Now, this is just in New York State. This is not necessarily the case in many other states across the country. So there are several programs, or twinned programs in this case. The expanded in-home services for the elderly program, which funds care in the home, and thereby avoids more expensive, both to individuals and to the state, Medicaid-funded institutionalization. And again, in recent years, this has been paired with another program, the Consumer-Directed Personal Assistance Program, which allows for the training and funding of family members to assist with care. So it begins to take on this problem of care that in many cases is uncompensated and allows it to be compensated. However, again, this is, this went into place in 2011, so it's a fairly new series of programs. Recently, just on the eve, actually, of the COVID-19 pandemic, the first wave here in New York, some of you may have heard of the Medicaid Redesign Team, or MRT2, that was convened. Basically a team that the governor put together to try to squeeze savings out of the Medicaid program. Governor Cuomo faced budget shortfalls and decided to target Medicaid for cuts, try to find savings there. So some of the areas that were targeted included long-term care plans and the aforementioned Consumer-Directed Personal Assistance Program for what could potentially be massive cuts. Now, COVID-19 pandemic kicked in, again, this occurred days before the lockdowns went into place, in mid-March. And under the terms of further federal assistance that came into play with the pandemic, one of the conditions was that there could not be significant revisions effectively to the Medicaid program. And so Cuomo and his administration were effectively required to shelve some of the massive cuts that they had envisioned if they were going to receive the further federal funding. So as of this moment, those cuts appear to still be on hold, but we don't know how long that reprieve effectively is going to last, whether it's going to carry over into next year or the years to come. So again, pandemic occurred and there was a bit of a reprieve when it came to cuts to these programs, but how long that reprieve lasts is anyone's guess, really, at the end of the day. So I've actually, I ran through that very quickly, I guess. So I am happy to take any questions or comments you may have. I don't know if I was anticipating the school bus or what, but I went through like the Micro Machines guy. I don't know. I'm dating myself by referencing the Micro Machines guy, but you know them anyway. So yeah, so I'm happy to take any questions or comments. And we can talk about, for instance, ways that we might reform this rather threadbare policy infrastructure that is currently in place. So, and with the caveat that I will have to run off and get my son off the bus shortly, but I will come back, I promise.